My name is Dr. Fernando Bianco. I work at a urology specialist group in Miami, Florida, and in the Urological Research Network as investigator and chief of that organization. So a patient needs a prostate biopsy when a couple things occur, right? One, if they have a family history of prostate cancer, very important, and they have an elevation in PSA, that's usually what starts triggering the events. The next thing happens, they get an MRI, if they can have it, and most do, and then you can see if there's abnormalities in the MRI. Based on that, you counsel the patient to have a biopsy. So traditionally, the biopsy will perform transrectally, or it can be done also transperineally. When you do it transrectally, you go through the rectum and then you take several samples. When you do it transperineally, you go in that immediate tissue that's above the rectum, in between the scrotal sac and the rectum, and you take the samples that way. I personally don't do transrectal biopsies anymore, although many urologists in the country do. The reasons why we did this Trexit from the rectum is because of the value that we see on transperineal biopsies, given that they have absence of infections, the inflammation seems to be a little bit less, and there's a very much thorough sampling of the prostate that to obtain with the rectum is a little bit more difficult. So that's a very good question. Both biopsy, transrectal or transperineal, will have some component of pain. So we do what's called a neurovascular bundle block on each side to try to decrease the pain. And if we do it transperineally, we do it through, we also numb the skin. And we can use nitros, just like when you go to the dentist, right? So despite that, on a scale from 0 to 10, biopsy pain scores by patients ranges between 2 and 3 for most of them. Okay, so that's another great question. So traditionally, when you do a transrectal biopsy without MRI, they were doing what's called, a 12-core template and trying to map the prostate. In the MRI era, that has changed because one of the things that we do, and you could see the graphics for that, is that we oversample the areas of interest, therefore the areas that are more suspicious. But we also do what's called systematic, which we do random samplings of other areas of the prostate because up to 12 to 15% of lesions that are cancer are not seen on MRIs. Undoubtedly, they will have some anxiety. So one of the things that we need to tell them is that, we will get the results. It takes about a week time. But they may feel a little bit discomfort on that day, depending on how the biopsy was conducted, right? They may feel different issues. When it's done transperineally, they may have a little bit of blood in the semen, or transrectally. I think that's a consistent one for a good 2 to 4 weeks, sometimes 5 weeks. They may have a little discomfort overnight, maybe an episode or two of little blood tinge in the urine, but for the most part, they recover quite expeditiously and they can go back to work the next day. When you do the biopsy transrectally today, some urologists will do ahead of time what's called a rectal swab to see what's the bacteria and the sensitivities, and therefore give patients antibiotics before the biopsy. When you do this transperineally, you don't really need to do all this. You can either give them prophylactic antibiotics or not, because you clean it up with betadine. So I personally haven't used that for the last 3 years. Now, they do have to do enemas. So they take an enema the night before and enema the morning of, and that's for both approaches. So that ensures that the rectal fossa is clean and has a very good ultrasound transmission. Another great question, and that's often a fear that patients have, whether the biopsy could spread the cancer, right? And the answer is no. And it's based on how the biopsy is conducted. So what happens when you put the biopsy needle in is that it is a very swift process when you deploy it. And what it consists of is that it exposes a little hole within the needle to the tissue, and then it sequesters the tissue that's immediately on top of it. So there's no exposure really between this sequestered tissue and the rest of it. So the answer is no. Will the biopsy cause permanent damage? The answer is no. Sometimes because of inflammation, patients may complain that they're having issues with their erections, or if they have very large prostates and a lot of samples were taken, then they may have even an episode of urinary retention or having difficulty urinating, requiring medication to help themselves. But these are very short-term symptoms. They are not, if they're driven by the biopsy, usually they're resolved in a matter of weeks. Well, today, I believe this is critical. So in the absence of patients, let's say, who have pacemakers or hip replacements or any other metal in the body that, forbade them from having MRIs, everybody should get an MRI before. That will orient the biopsy, that will give you light, whether you do it, using fusion registration software, which is what we do, or whether you do it even cognitively. You want to make sure that you have the MRI information. And then you want to sample more, again, the areas that have suspicion, but also sample the areas that doesn't.